rheumatoid or neutropenia with splenomegaly and long-standing history of rheumatoid arthritis. This is Feltis syndrome. So this is Feltis syndrome. Feltis syndrome is a complication of rheumatoid arthritis. It consists of combination rheumatoid arthritis, neutropenia, splenomegaly, and tends to affect rheumatoid arthritis long-standing duration. The main differential diagnosis is drug-induced myeloplastia. However, this would not easily account for the presence of splenomegaly. Okay. Splenomegaly will not be the part of this one. A variety of extra-articular complications occur in patients with rheumatoid arthritis. Respiratory complications include respiratory pulmonary fibrosis, pleural effusion, pulmonary nodules, bronchiolitis obliterans, methotrexate pneumonitis, and pleurisy. So bronchiolitis obliterans can give you a picture of obstructive lung disease, and the rest of the things can give you a sort of restrictive lung disease. So there can be a combination of the two. Ocular keratoconjunctivitis sicca, most common. Episcleritis, scleritis, corneal ulceration, keratitis, steroid-induced cataracts, chloroquine retinopathy. So all these you can see the ocular manifestations in a patient of rheumatoid arthritis. Osteoporosis also, ischemic heart disease, rheumatoid arthritis carries a similar risk to type 2 diabetes mellitus. And increased risk of infections and depression. Less common, Feltis syndrome, S and W. So rheumatoid arthritis, splenomegaly, low white cell count, amyloidosis can also occur rarely, less common. So which of the following is the next step in the management? Which of the following is the next step in evaluating his foot injury? 58-year-old, so there are some tests, 58-year-old man who has no fixed abode, homeless, comes to the emergency department because he is unable to walk, and he has a history of alcoholism, type 2 diabetes, and his main complaint is that his shoes have worn out, and because of loss of sedation, he didn't notice that he had stepped on a nail. Loss of sensation. Because of loss of sensation, he didn't notice that he had stepped on a nail. In total, this lesion on his right foot has been present for approximately 3 weeks. Which of the following is the next step in evaluating his foot injury? Inflammatory markers, MRI of the foot, plain X-ray of the foot.
X-ray, I think X-ray.
First of all, X-ray of the foot.
Yeah.
Then later on, we can see any other problem. So the key next step here, gather useful information about the extent of any foot infection.
You have to exclude the bone involvement.
Bone demineralization, cortical elevated periosteum or osteum. Many patients progress from a plain X-ray onto MRI imaging of the foot for further evaluation of the extent of infection and to guide potential operative approaches for debridement. And inflammatory marker, a very non-specific marker of infection, and ultrasound of the foot is only useful to visualize soft tissue swelling or collection of pus or fluid. So inflammatory markers are a very non-specific marker of infection, and ultrasound of the foot is only useful to visualize soft tissue swelling. very non-specific organ infection. And ultrasound of the foot is only useful to visualize soft tissue swelling or collection of pus or fluid. A wound swab is likely to show a range of bacteria. This is what drives selection of a broader spectrum antibiotics such as comoxiclav in the diabetic population. Osteomyelitis describes the infection world may be subclassified into hematogenous osteomyelitis or non-hematogenous osteomyelitis. Hematogenous osteomyelitis results from bacteremia, usually monomicrobial, most common form in children. Vertebral osteomyelitis is the most common form of hematogenous osteomyelitis in adults. So hematogenous is the most common cause of osteomyelitis in children, and vertebral osteomyelitis is the most common cause form of hematogenous osteomyelitis in adults. And risk factor includes sickle cell anemia, IV drug use, or HIV infective endocarditis. Okay. Non-hematogenous osteomyelitis results from the contiguous spread of infection from adjacent soft tissues to the bone or from the direct injury trauma to the bone. Is often by polymicrobial, most common form in adults. Risk factors include diabetic foot, ulcers, pressure sores, diabetes mellitus, peripheral arterial disease. Staphylococcus is the most common cause except in patients with sickle cell disease where Salmonella species predominate. I think malaria is also part of this one. Salmonella, in malaria and sickle cell anemia. Investigation, MRI is the imaging modality of choice with a sensitivity 90 to 100%. And management flucloxacin for 6 weeks, clindamycin if penicillin allergic. So what is the most appropriate treatment? Colchicine, buxostat, IM steroid, ibuprofen, oral prednisolone. Creatinine is 230, urea is 14, CRP is 32. So this is 69-year-old man attends the medical unit with an acutely hot and swollen joint. The swelling is limited to the first metatarsophalangeal, so this is most likely gout and is causing him severe discomfort. He stated that he has had this problem before and had it successfully treated, but the medicine used caused him to have severe diarrhea. So he was on colchicine. On assumption, their first MTPJ is swollen and red and very tender to touch, and there is limited movement, and when then they try to walk, it causes severe pain. Their PMH includes CKD, gout, osteoarthritis, and angina. Okay. So you suspect the diagnosis is an acute flare of gout. What is the most appropriate treatment? So in an acute flare, colchicine we cannot give because already used and diarrhea and they stop. We will go with the ibuprofen. And creatinine, I think with this level of creatinine, what do
As
you
renal
think we
failure,
can
you
give?
can't give non-steroid here.
Okay, no steroid we cannot give. We will give the oral prednisolone
And you
or IM
test here.
steroid. Yeah, oral prednisolone, I think the best. For gout, if NSAIDs and colchicine are content not tolerated, the next option is the steroid. So if the renal impairment is there, like we see the high levels of urea creatinine, we cannot give the NSAID. The answer is oral prednisolone. is the most appropriate treatment for this man. He has gout affecting one small joint with a relative contraindication to NSAIDs and colchicine, asthma, previous intolerance of colchicine, and renal disease. So there are so many things, The patient is having asthma also. CKD, gout, osteoarthritis, angina. Anyway, they mentioned, I think in our patient there is no asthma, I think. But anyway, they mentioned that you cannot use this thing. There is intolerance of colchicine and renal disease. Fluvoxamine is not an appropriate choice as this is the gout prophylaxis medication. An alternative treatment would be intra-articular injection of steroid in this case, but not an IM steroid injection. So when they have written IM steroid, this is wrong. It should be intra-articular steroid, What is the likely diagnosis? Hypokalemic periodic paralysis, von Jates disease, McArdle's disease, Pompe's disease, and Koch's disease. 21-year-old male presents presents to his GP complaining of muscle cramps that prevent him from competing in his local park 5-kilometer race. He has always had muscle pains when warming up with exercise, but these gradually diminish after 20 minutes. So this is second wind phenomena. And this is seen in McArdle's disease. There was no weakness and no abnormalities on neurological examination. And this is McArdle's, yes, Dr. Mustafa. There was no weakness, no abnormalities on neurological exam. Creatinine was elevated at 1,215 international units per liter, and myoglobin was noted on urine analysis. The EMG demonstrated myotonic discharges and fibrillations. So this is McArdle's disease. McArdle's disease, also known as myophosphorylase deficiency or glycogen storage disease 5, often presents in adolescents with exercise intolerance, cramps, and weakness. Unfortunately, it is often misdiagnosed as chronic fatigue syndrome. Inheritance is autosomal recessive. The diagnostic clues are no rise in venous blood lactate on exercise, and muscle biopsy demonstrates elevated glucose concentration, muscle phosphorylase deficiency. Investigation usually reveal an elevated CK and myoglobinuria. Diagnosis is confirmed with forearm muscle exercise testing or genetic testing. Management involves avoidance of low carbohydrate diets and low intensity aerobic exercise. Autosomal recessive type 4 glycogen storage disease caused by the myophosphorylase deficiency. This causes decreased muscle glycogenolysis. So glycogen will not be lysed to provide the glucose necessary for the production of ATP. Features: muscle pain, stiffness following exercise, muscle cramps, myoglobinuria, and low lactate levels during exercise. So what is the best strategy for gout prophylaxis in this patient? Okay, reduced dose of allopurinol. Let us see what is EGFR is 45, so we can reduce the allopurinol. Okay, so you remember, guys, we from 10 to 50 ml per minute. If the GFR, we can decrease the dose. If less than 10, we cannot use allopurinol. So on other medical problems include type 2 diabetes, hypertension, hypercholesterolemia, chronic renal failure. Regular medications were ramipril, metformin, simvastatin. On examination, the patient was noted to be obese without evidence of current joint inflammation. Tophi were noted on examination of the patient's ears. And blood tests taken prior to the clinic attendance are as shown below. We have seen the blood tests. Colchicine and NSAIDs had been used effectively to provide symptomatic relief to the patient during an acute attack. Allopurinol had been previously tried as prophylaxis at a dose of 200 milligram daily, although was stopped after the patient's renal function was noted to have deteriorated after allopurinol was initiated. Lifestyle modifications have also been attempted. Noted to have deteriorated after allopurinol was initiated. I think we can reduce the dose further. So this is simply needle-shaped crystals with negative birefringence gout patient, and I think we will go with the reduced dose of allopurinol. Dr. Haji, any other idea? No, febuxostat. Urate lowering therapy is indicated in recurrent attacks of gout, although there are no firm guidelines as to when to initiate therapy. Target serum uric acid levels are usually taken as less than 360 micromole per liter. Febuxostat is a non-purine xanthine oxidase inhibitor approved by NICE for use in individuals such as this patient who are intolerant of allopurinol or in whom allopurinol is contraindicated. So they are saying intolerant of allopurinol. So due to the allopurinol previously given 200 microgram or milligram, sorry, 200 milligram, it deteriorated the renal function. So they are saying once there is deterioration of renal function with allopurinol, you have to stop. Prednisolone, colchicine, naproxen are all used in the acute treatment of gout. Extended use of colchicine and NSAIDs can be considered to reduce the risk of gout relapse during the instigation of allopurinol. But have no role as prophylactic therapy in isolation. So you can use the prednisolone, colchicine, naproxen are all used in the acute treatment of gout. Extended use of this colchicine and NSAID can be considered to reduce the risk of gout relapse during the instigation of the allopurinol therapy. Okay, in that time you can go with the extended use of colchicine and NSAIDs if you think that the gout will flare up. Allopurinol can cause renal, hepatic, and severe skin reactions. Allopurinol hypersensitivity syndrome, and is best avoided in the patients in this patient given previous worsening of renal function with a relatively low dose of allopurinol.
So why the answer febuxostat? Why not reduce the dose of allopurinol?
Dr. Mustafa, actually they are saying that here they have explained, and I will show you 1 minute. Let me just copy paste the things in the explanation. Okay, 1 minute. So they are saying that allopurinol can cause renal, hepatic, and severe skin reactions, but and is best avoided in this patient given previous worsening of the renal function.
Yes, agree, but we can give adjusted dose of allopurinol. We can adjust
but here according to past medicine, maybe they are wrong. They are saying that with 200 milligram of allopurinol, he got the deterioration in renal function. Allopurinol had previously tried as prophylaxis at a dose of 200 milligram daily, although was stopped after the patient's renal function was noted to have deteriorated after allopurinol was initiated. So this is the point they are saying. If you give the allopurinol either 100 or 200 milligram, and then if there is deterioration of the renal function, then you need to stop the drug. It is there according to past medicine.
It is according to past medicine, but according to your EULAR study, I think it's a remaining drug of choice.
Yeah.
The European guidelines of rheumatology.
Once if there is a skin reaction and other complications, why should you give?
No, there are no other complications in our patient, but they
said
are saying
skin and this renal and hepatic.
No. This they are telling that generally speaking, whenever there is severe skin reaction or hepatic or renal problem, you will avoid this drug.
In this patient.
Yeah, they are saying this allopurinol can cause renal, hepatic, severe skin reactions, and is best avoided in this patient given. Okay, let us see the discussion also. You should try allopurinol again. It is not contraindicated with this EGFR. This is what Dr. Mustafa is saying. Febuxostat has a black box warning for cardiac side effect, and this patient has hypertension, hypercholesterolemia, and diabetes mellitus. It is very risky to start such medication. And febuxostat has a very similar side effect profile to allopurinol, similar limitation. Most would try decreasing the dose of allopurinol first. Nice BNF on allopurinol, maximum 100 milligram, increased only if response inadequate, and severe impairment, reduced daily dose below to 100 milligram, or increased dose interval. If still dose to maintain plasma oxypurinol constantly below 100, this, so it should be okay to go back to allopurinol, isn't it? The way I see it, allopurinol can be given up to 900 milligrams daily, yes. So 200 milligrams is a low dose, and the patient's renal function still deteriorated. So better to try something altogether different, something else. What is the target serum uric acid level? 360. This we know already that if recurrent problems, 300, otherwise 360. But Dr. I think Dr. Mustafa is also right. According to what is Dr. Mustafa according to the European Society of Rheumatology?
Your society, allopurinol is drug of choice. We can adjust it until GFR 30.
Okay. Less than 10, less than 10.
Yeah.
Okay. Okay. So anyway, confirm with the other resources also, you are right. Okay. So until now, we that problem is that for Buxostat, I was going with a reduced dose allopurinol, but anyway, no problem. We will see. We will flag the question and confirm with other people also. So what is the most optimal treatment? Optimize the diabetic control, riluzole and IV immunoglobulin, IV with methylprednisolone, lumbar puncture. An MRI scan was performed of his lumbosacral plexus, demonstrating no appreciable structural lesion. Nerve connection studies and EMG are awaited. What is the most optimal treatment? Optimize diabetic control, riluzole, IV immunoglobulin, IV methylprednisolone, and lumbar puncture. So what is this patient? Let us see the investigations. HB135 platelet is normal. WBC okay, sodium potassium acceptable. Urea is little high, CRP is normal, creatine kinase is normal. HbA1c is high, diabetic patient, TSH is 2.1, okay, normal, and free, okay. So most of our things are normal, except urea here. Okay. 70-year-old male from the Dominican Republic presents 4-month history of constant bilateral anterior thigh pain and lower limb weakness, starting first on the left before progressing to the bilateral symptoms, and he reports being an extremely active man prior to these symptoms, continued to work as a landscaper gardener until 4 months ago, and now he is a wheelchair and bed-bound, and he denies any history of trauma to his hips, previous tuberculosis infection, contact with heavy metals, and his thigh pain appears excruciating, described as burning in nature along the anterior aspect of both thighs to the origin of the patella tendon bilaterally. Now the anterior aspects of the thighs, okay. And he reports no recent weight loss, pyrexia, or skin changes. His PMH includes hypertension, hypercholesterolemia, hypothyroidism, type 2 diabetes mellitus. diagnosed 6 years ago. So these are the history. Patient with mildly reduced muscle bulk in bilateral hip flexors and bilateral fasciculations in both legs. Examination power demonstrates 2 out of 5 bilaterally in his flexion, 4 by 5 hip extension bilaterally, and 5 by 5 all other lower limb. Sensory examination revealed reduced sensation to cotton wool in both thighs and distal feet, reduced proprioception in both toes. Reflexes were 2 plus at both the knee jerks, absent ankle jerks bilaterally, and downgoing planters bilaterally. His blood tests are as follows. So what is this? What is the most optimal treatment? Optimal is diabetic control, riluzole, IV immunoglobulin, and IV methylprednisolone, and lumbar puncture. So what do you think can be the answer here? Optimal diabetes control. So is it related to maybe we have to go with methylprednisolone? I think is out of order now at this stage. It will not work here. What is this? Discitis or what? What is this? Discitis or what, Dr. Dala? Or quadricular syndrome? Or what is this? I don't understand. No, I have optimized diabetic control. So Dr. Mustafa, what he is saying, he has taken something from the past test. Yani. Okay, we will read 1 minute. But what is this? He has taken from the past test something. We will read. So what is the most, because past test is always superior here. So optimized diabetic control, riluzole, I will have a number mentioned. So this is diabetic neuropathy or what?
Proximal diabetes.
Anterior aspect of both thighs to the origin of the patella. I think this is, I don't understand what is this. Anyway, we will go with the one option and see. The positive symptoms include bilateral proximal myopathy, severe neuropathic pain in thighs, and absence of lumbosacral structural lesions. In an HIV negative patient, the diagnosis is most likely diabetic amyotrophy. The onset of proximal pain as a result of microvascular lumbosacral plexopathy is usually asymmetric before becoming more symmetric. So this is lumbosacral plexopathy, microvascular. Lack of upper motor neuron signs makes this unlikely to be motor neuron disease and hence requiring riluzole. So riluzole is used in the upper motor neuron lesions. Involvement of sensory components rules out. Just 1 minute, I want to note one thing, guys. Nida Tariq. So this is signs of motor Okay, so let us see what, after this finishing this question, we will see what Dr. Mustafa has shared. The lack of upper motor neuron signs makes this unlikely to be motor neuron disease, and hence requiring riluzole. The involvement of sensory components rules out multifocal motor neuropathy with conduction block, typically responsive to immunoglobulins. Okay, the proximal location of the symptoms and prominent neuropathic pain is classical of amyotrophy instead of chronic inflammatory demyelinating polyneuropathy, for which IV methylprednisolone can be therapeutic. So they have given different options where you can use the different treatments. The best treatment for diabetic amyotrophy is to optimize blood sugar control and symptomatic treatment neuropathic agents. Most patients report at least partial, if not full, motor recovery and much improved pain symptoms. European Federation of Neurological Societies describe typical CIDP. Okay, this is something different. Okay, let's go to this one. Diabetic amyotrophy. is also known as proximal diabetic neuropathy. The later term is probably more useful as it describes more accurately the etiology of the condition. So this is proximal diabetic neuropathy. Typical features include pain is usually in the first symptom, often in the hips or buttocks. This followed by weakness, for example, difficulty getting out of a chair. Okay, let us see what Dr. Is it asymmetrical? Yes, it is. It was asymmetrical and then it became symmetrical, Dr. Imtiaz here. So let us see what is being shared by Dr. Mustafa. This is, I think, he has taken from the past test, and I will share with you here the screen, different screen. Okay. So here we can see, we can make it a big one. Okay, recommendations for a choice of initial urine lowering therapy in a patients with gout. Okay. Panel strongly recommend allopurinol as the preferred first line. Okay, for patients starting any ULT, we strongly recommend allopurinol over all other ULT as the preferred first line agent for all patients, including in those with a CKD stage equal to or more than 3. We strongly recommend a xanthine oxidase inhibitor over probenecid for those with CKD stage equal to or more than 3. For allopurinol febuxostat, we strongly recommend starting at a low dose with subsequent dose titration to target over starting at a higher dose. For example, less than or equal to 100 milligram per day and lower in patients with CKD for allopurinol, or less than 40 milligram or equal to 40 milligram per day for febuxostat. They are saying equal to or less than 100 milligram per day for the allopurinol. So they are saying that with subsequent dose titration to target over starting at a higher dose. Okay, for example, you will start with the less than or equal to 100 milligram per day and lower in the patients with the CKD. Okay, for allopurinol. For probenecid, we additionally starting at a low dose once daily or twice daily with dose titration over starting at a high dose. We strongly recommend initiating concomitant anti-inflammatory prophylaxis therapy, for example, colchicine and NSAIDs, over no anti-inflammatory prophylaxis. The choice of specific anti-inflammatory prophylaxis should be based upon patient factors. We strongly recommend anticoagulant continuing prophylaxis for 3 to 6 months rather than less than 3 months, with ongoing evaluation and continued prophylaxis as needed if the patient continues to experience flares. So it means, Dr. Mustafa, if somebody is having hyperuricemia and no acute attacks of gout, but they want to eat everything which is prohibited, as a lifestyle modification factor. So we can start with the allopurinol alone, isn't it? We don't need in that case to go the NSAIDs, to give the NSAIDs or colchicine. But I think here they didn't mention about what you can say that once you started, if there will be deterioration in the kidney function further, you can continue with it or not. That is one question that is remained, behind. That is the point. Otherwise, you are right that we can give with low doses and then increase to the higher doses. Okay. So I will share the other thing, some other question now, next question. So we are not sure. In past test we will see, and we will see in the up to date also. If the up to date also saying that there is no issue, then we can continue with the low dose of this allopurinol. An X-ray of the patient's hip is performed as below. So here you can see there is irregularity. Okay. 40-55 presents increasing right-sided groin pain on activity, and she recently joined a gym in an attempt to lose weight after being diagnosed with obesity. She has been started a number of activities, including cycling, running, aerobic classes. The patient first noted the pain 3 months ago following a running session. She was able to continue with her exercise, but the pain has become progressively worse, and she now finds her gym sessions very difficult to complete. Other than being overweight, the patient has known hyperthyroidism and asthma, which both were well controlled on treatment. An X-ray of the patient's hip is performed as follows. What is the most likely diagnosis? Avascular necrosis can be one, and the osteoarthritis. So what do you think here? I think this is avascular necrosis most likely of the head. Irregular, too much irregular. And the size of this one is also decreased. So what do you think, Dr. Zala? There is some sclerosis here. You see the sclerosis?
Yeah, sclerosis is definite there, Dr. Tariq.
It is
But
part of the, no, sclerosis will occur in case of avascular necrosis or what do you think?
in avascular
osteoarthritis.
necrosis, there is a irregularity, this I know. But
Yeah.
what is the other options?
There is osteoarthritis also. So both can be there, but I am more in favor of avascular necrosis.
Okay.
But it can be osteoarthritis
Yeah,
as well.
osteoarthritis. See, Dr. Tariq, there is this extra bone formation, osteophytes is there also.
Yes, let us see. Yes,
So can we,
osteoarthritis. CRP will be normal, ESR will be high. Okay. And complement C3C will be, this is normal CRP. Okay. A raised CRP in a patient with known SLE may indicate an underlying infection. So this we know already. See, they give you something rare from this one SLE.
Yes.
Yeah. No problem. Little headache for me, by reading. You can read something here, Dr. Zala. You are on your computer, Dr. Zala?
Yes, I'm on from computer.
Okay, please see what is this.
You want me to read, Dr. Tariq?
Yes, please read. Yeah, read the question.
What is the most likely underlying cause of the back pain? Osteomyelitis, multiple myeloma, Pott's disease, metastatic lung cancer, osteoporosis. Okay, Dr. Arif.
We
Show me
can
the.
see we can see the image first.
Yeah, not visible. Yes. So they said that Pott's disease or
You see
there.
here the vertebrae
Yeah.
here.
After this, again this one.
Yeah. So two are, there is a collapse of the vertebrae here.
Yeah. So what is the reason of that collapse?
Okay, see.
See the option, Tariq?
No problem. Just read the question.
Okay. 71 years old man with the history of chronic obstructive pulmonary disease is investigated for back pain. Over the past 10 years, he had numerous admissions for infective exacerbation of COPD and currently uses long-term oxygen therapy. The pain comes on suddenly while he was at his local supermarket. MRI scan is okay. So he was, what they said, what is the history? 1 minute, Dr. Tariq. Go up.
Yeah.
COPD. It means he
This
was
is
on steroids also.
Yeah, so it can be multiple myeloma, Pott's disease, metastatic lung cancer, osteoporosis. So he is taking the, I think,
Steroids, I think COPD.
he has numerous admissions for infective excellence here. Currently used long term. Pain came on suddenly while he was at his local supermarket.
So this is fracture, I think.
Yeah.
Vertical.
So what do you think? It can be osteomyelitis like thing? Yeah?
Osteomyelitis, just there is a pain. I think it's steroids, osteoporosis, I think maybe. Cannot be osteoporosis.
Cannot be, can be, yes. Steroid osteoporosis, most likely. You are right. So we will go with the osteoporotic fractures, vertebral fractures, okay? We will go with the osteoporosis, okay? Osteomyelitis will give you some other color, I think, yes.
Yeah.
Yes, okay. Steroid-induced osteoporosis, yes.
MRI shows osteoporotic fracture of the 10th and 12th thoracic vertebra. This is likely to have been caused by repeated courses of steroids to treat exacerbation of COPD. Osteoporotic
Yes.
movement.
Yes,
Okay.
okay. We'll go to the next question.
Okay.
Okay. 1 minute. So what is this?
What is the most likely diagnosis? Eosinophilic granulomatosis with polyangiitis, granulomatous with polyangiitis, SLE, rheumatoid arthritis, relapsing polychondritis.
Okay, so investigations.
Hemoglobin is if 115, platelet normal, WBC high, neutrophils high, lymphocytes
Normal.
2
Normal.
normal. Eosinophil high also.
Yes.
C3 normal, ANA negative, rheumatoid factor positive, anti-CCP negative,
Yeah.
anti-Smith negative, okay, C4 normal, P-ANCA negative, CRP is high, creatinine, urea, potassium, sodium, all normal. So
Yeah. So
eosinophil is
here
a-
we have the rheumatoid factor positivity here.
yeah, rheumatoid factor positive, but anti-CCP negative, anti-Smith negative, and eosinophils are more. If eosinophil is more,
Okay,
in the
let us see. Let
yeah,
us read the slide.
Pianka is negative.
Yeah.
So,
Okay.
58 years old man present with the malaise and fever. He states that he has been feeling unwell for several months. His main complaint are intermittent swelling and pain of his right ear. Right ear, intermittent pain and swelling, painful red eyes, and arthralgia. Red eyes, arthralgia. He has no past
Well,
medical.
this is polychondritis, doctor. Relapsing polychondritis.
Auricular swelling, yeah. Bilateral anterior uveitis, and a symmetrical small joint polyarthritis.
This is most likely, relapsing polychondritis, I think.
Okay.
Yes.
Uh, Relapsing polychondritis is a multi-system systemic condition which most commonly causes relapsing episodes of auricular chondritis. Relapsing polychondritis is a multi-systemic condition characterized by repeated episodes of inflammation and deterioration of cartilage. It is often a painful disease which can cause joint deformity and may be life-threatening if the respiratory tract, heart valve, or blood vessels are affected. If lung, heart valve, and blood vessels are affected, then life-threatening. Otherwise, painful disease and causing joint deformity. The exact mechanism is poorly understood, but it is thought to be related to an immune-mediated attack on cartilage protein. The history in this case is suggestive of relapsing polychondritis. However, the clinical features are non-specific and occur due to many of the other options. The laboratory date is therefore laboratory date
Data. Data.
data. Laboratory data is therefore of great use in narrowing down the differential diagnosis. A normal C3, C4 and negative ANA makes SLE unlikely, right? A negative PNCA and CNCA make granulomatosis and polyangiitis, eosinophilic granulomatosis less likely. A negative anti-CCP makes rheumatoid arthritis less likely. Although RHF is positive, this is very non-specific and is positive in many other diseases and in the healthy general population also. So RH rheumatoid factor is present in other diseases also and even in normal cases also. So the history was important.
10% of the normal 10% of the normal population has uh, this
yeah,
RH factor positive here.
yeah.
Let us see discussion here.
So this is polychondritis, relapsing
Yes.
polychondritis.
Yes. Okay. So you can see here again 1 minute.
Yeah, we can read this because relapsing polychondritis is a multi-system condition characterized by repeated episodes, inflammation, deterioration of cartilage. This most commonly affect the ears, however, can affect other parts of the body, such as the nose and joints. And wherever there is a cartilage, they can affect, I think, nose,
Yes.
ears.
Yes.
Key feature, ear auricular chondritis, hearing loss, vertigo, nasal chondritis, saddle nose deformity, respiratory tract, hoarseness, aphonia, wheezing, inspiratory striders. Okay, aphonia, there will be no voice, wheezing can occur because of this cartilages in the air spaces, maybe effect on that. Inspiratory stridor, ocular episcleritis, scleritis, iritis, and conjunctivitis sicca. Joint arthralgia, less commonly cardiac valvular regurgitation. Cranial nerve palsies, peripheral neuropathy, renal dysfunction. These are the less common. Cardiac, nerves, and renal involvement are less common. Cranial nerves and peripheral nerves, cardiac valvular disease, and renal dysfunction. Diagnosis varies scoring system based on clinical, pathological, and radiological criteria. Treatment induce remission steroids and maintenance by azathioprine, methotrexate, cyclosporin, and cyclophosphamide.
Okay, so
Steroids for remission and
so
maintenance. Maintenance.
induce
Yes,
steroid
sorry.
maintenance. Yeah, for maintenance demands, we are using demands.
Mm.
Okay, and cyclosporin and steroids for the remission.
Mm.
So it can affect any area wherever there is cartilage, it will affect, like in the heart valves, cranial nerve palsies may be occur, peripheral neuropathies, and renal dysfunction can occur. So along with the cartilage, it can affect.
Yeah, can affect other areas also. They can, if the other organs involve, it will be life-threatening, like if heart involvement, lung involvement.
Yeah. Okay.
So this is what is the most important? Immediate management. 66 years old Caucasian female present with 3 weeks history of worsening headache, 3 weeks. 66, 3 weeks history, worsening headache, and 2-day history of shortness of the breath. She reports disturbed sleeping at the night due to an inability to lie down. Due to her shortness of breath, she has no known past medical history and drug history. On examination, you note bilateral sphincter hemorrhage, 4 on the right and 2 on the left, with calcium deposits distally and black spots in the pulp of the fingers. Perioral skin puckering is also noted. Perioral skin puckering.
Systemic.
Cardiovascular examination is unremarkable. Chest examination reveals bilateral coarse inspiratory crackles. Neurological examination is unremarkable, except fundoscopy revealing papilledema. Cotton wool spots and phlegm hemorrhages. The patient is apyrexic, sets 95 on 2 liters, respiratory rate 24, blood pressure 195 by 115, heart rate 90, regular, chest x-ray demonstrate bilateral pleural effusion. Bilateral pleural effusion.
Again, this is a scleroderma renal crisis.
Yeah, high BP and bilateral alveolar shadowing. What is the most important? Immediate.
Yeah, we'll go with the oral captopril.
Patient present with the sign and cutaneous manifestation of systemic sclerosis, grade 4 hypertension, retinopathy, and heart failure. She is scleroderma renal crisis, an emergency that, if left untreated, is fatal. The optimal drug of choice is an AC inhibitor, preferably captopril, which has been trialed with the greatest experience, but other ACE are also likely to be beneficial. In a 15 years prospective cohort, 1-year survival increased from 15 to 76% with the use of ACE against other antihypertensive. Steroids should be strictly avoided. Steroids should be avoided in SRC. They increase the risk of SRC prior to the event and may exacerbate SRC. Okay. If SRC patient is there, if we use steroid, they will precipitate. They will increase the risk of SRC prior to the event. And if there is an event, they will exacerbate. In the acute setting, renal dialysis may be required in patients who progress to and stage renal failure despite ACE treatment. Okay.
So this is important, Dr. Zanans.
Yeah, steroids must not given to scleroderma renal crisis patient.
Yeah. I think in systemic sclerosis, we should not give up. What is your idea?
Yeah, systemic sclerosis. You are right.
it will make a problem, yani.
So the heartburn may be explained by which is this is not that question, huh?
Pardon?
Which one? Where we are, Dr. Tariq?
Just 1 minute.
Okay.
Just I am just copy pasting the things.
Okay.
Okay, so that is enough, I think, for strength philosophy. We have read already, and individually we can read on that. We will go to the next, okay, and next question. So, what is the likely diagnosis? Okay, yes, Dr. Dali.
Yeah. Farmer's lung, hypersensitivity pneumonitis, interstitial lung disease, methotrexate-induced pneumonitis, pneumocystis jirovecii, pneumonia, viral pneumonitis. Hemoglobin is okay. Platelet is also okay, but at lower limit. WBC, neutrophils, lymphocytes, and monocytes, eosinophils are more.
Yes.
A chest
Yes.
X-ray shows diffuse ground glass opacities and infiltrates, predominantly affecting the lower lobe. Ground glass opacities and lower lobe involvement.
Yes. Okay.
62 years old man to ED with a 6-week history of dry cough and worsening breathlessness. On examination, his temperature was 38.4 and he had fine biobasal crackles on inspiration. His past medical history was significant for hypertension and psoriatic arthritis, for which he had been taking methotrexate for 2 years.
So this is the cause. This is the
Yeah,
cause.
methotrexate induced, yeah. Other medication include amlodipine and ramipril. He worked as a farmer and prior to his illness had been quite well. A chest X-ray, ground glass. Okay, methotrexate induced pneumonitis.
We can remember the D for drugs, D for down.
Yeah.
So it will affect the lower zones.
Lower lobe, yeah. Methotrexate may cause pneumonitis, typically presents with the cough, dyspnea, and fever. The patient has presented with cough, dyspnea, and fever with bibasal, fine crackles while on methotrexate. This combined with presence of infiltrates on chest X-ray should raise the suspicion of methotrexate pneumonitis. Hypersensitivity pneumonitis, former lungs would not be an unreasonable differential diagnosis. However, in acute farmer's lung patient would have a present with a short history of fever, chills, malaise, headache, and myalgia along side breathlessness and dry cough. Okay, hypersensitive in
That can be the another differential.
Yeah.
Okay, just we will go to
So
the next
why
question.
we choose here methotrexate, please?
Methotrexate here because lower lobe pneumonitis is caused by methotrexate, and hypersensitivity pneumonitis usually affects the upper lobes.
Upper lobe, yeah. Farmer's
That
lung,
is one of the reason. And they are saying that in that case, this is a 6-week history of dry cough. But I think with hypersensitivity pneumonitis, it will be a short acute history, like this. Would not be an unreasonable diagnosis here. However, in acute form of the lung, patients would, however, present with a short history of fevers. Patient will not say, I am suffering for the last fevers for the last 6 weeks. It is not like that.
So
Maybe
short,
only
short time
duration.
and upper lobe. It will be
Yeah,
farmer lobe.
Yes. So fever, chills, malaise, and headache, and myalgia, and their duration of symptoms will be short, and the upper lobe fibrosis will be there. Okay.
Okay. What is the likely diagnosis? Urine dip, blood 3+, leukocytes negative, ultrasound KUB, no hydronephrosis or renal lesion scenes, anticardiolipin antibodies positive, creatinine, urea, potassium, sodium normal. On examination, she is standard in right loin only. Her blood pressure is 180 by 105, hypertension, heart rate 85, respiratory rate 22.
So it can be this one, Dr. Dalla, we will see.
Yeah. 31 years old woman with presence with 3 days of right-sided loin pain with 2 episodes of blood in urine. She feels unwell and lethargic but denies any fever or urinary dysuria. She is usually well and has had 2 urinary tract infection previously. She is being seen by the anti. She is being seen by the anticoagulants clinic due to several miscarriages. Okay, and is due for review next week. Her maternal aunt has previous renal calculi. She takes no regular medication and presents uh, at present. On examination, she is tender in the right loin area
Yeah,
only.
this is due to the,
Blood
you know,
pressure is
this is
high.
antiphospholipid antibody syndrome like
Yeah,
fever.
yeah. This anticardiolipin is
And
positive.
anticardiolipin will be positive, and
They are
it
prone
will lead
to yes,
to inner vein
anticoagulation.
thrombosis.
Ah,
Yes.
that's why your blood in urine.
Yes.
Patients with the antiphospholipid syndrome are at increased risk of thrombosis and loin pain with hematuria and hypercoagulable state is most likely a renal thrombus. Although not formally diagnosed, she has positive antibodies and multiple miscarriages diagnostic of APS, antiphospholipid syndrome. She could have a renal calculus, though this less often has frank hematuria and there are no risk factor for it. A UTI is unlikely given the lack of lower urinary tract symptoms. Tubulointerstitial nephritis often has a rash, and the urine dip has leukocytes and eosinophilic cast on microscopy. If there is a tubulointerstitial nephritis, there will be eosinophilic cast on microscopy and leukocytes. And
Yes.
yeah,
So it will
these,
be, you know, like tubular cast or eosinophilic cast in tubular
mm,
intestinal nephritis,
mm,
and or it can be, you know, white cell cast. You can say so. Eosinophilic cast is the
eosinophilic.
white cell cast. Yeah,
Mm,
and urine dip has leukocytes. You know.
yeah.
Okay.
Antiphospholipid syndrome.
Yes.
Antiphospholipid syndrome is an acquired disorder characterized by predisposition to both venous and arterial thrombosis, recurrent fetal loss, and thrombocytopenia. It may occur as a primary disorder or secondary to other conditions, most commonly systemic lupus erythematosus. Around 30% of patients with SLE has positive antiphospholipid syndrome antibodies. A key point for the exam is to appreciate that antiphospholipid syndrome causes a paradoxical rise in APTT. Okay. This is due to an ex vivo reaction of the lupus anticoagulants autoantibodies with phospholipids involved in the coagulation cascade. Okay.
You know, I have my notes in the part one subscription, but here I don't have my notes. I searched in detail and then I copy pasted in part one this topic, you know.
Hmm.
But I can find it again, no problem. Just we
A
will
key
copy.
point of the exam. Okay.
I will
Exam.
just I will copy paste this one and I will find this. What is the mechanism behind actually?
Okay. Okay.
I found this in part one because you know, most of the task of research was on my shoulders. So, but I forget the real mechanism. You know, after 3 4 years, you forget the things.
Yeah. Yeah.
Okay, okay. Associations other than SLE.
Hmm. Other autoimmune disorders, lymphoproliferative disorders, and phenothiazine.
Yes.
Lymphoproliferative autoimmune disorder and phenothiazine. Feature venous and arterial thrombosis, miscarriages, recurrent levadoreticularis. Other features, preeclampsia, pulmonary hypertension. Yeah, these patients can have preeclampsia and pulmonary hypertension, and venous arterial thrombosis, miscarriages, levadoreticularis preeclampsia. Investigation antibodies, anticardiolipin antibodies, anti-beta 2 glycoprotein 1, anti-beta 2 glycoprotein 1 antibodies, lupus anticoagulant. Okay, with these two we know anti-cardiolipin and lupus anticoagulant, and there is anti-beta 2 glycoprotein 1 also. Anti-beta 2 glycoprotein.
Dr. Rizana, what do you think? This is GPI or GP1? This one.
GP1, I think.
Okay.
Anti-beta 2 glycoprotein 1. It is written
Yeah.
already, Tariq, and in the
Yeah.
make short in the bracket.
Yeah.
Lupus anticoagulant, thrombocytopenia, prolonged APTT. Management based on the EULAR guideline, primary thromboprophylaxis, low dose aspirin. In primary thromboprophylaxis, we will give low dose aspirin. Secondary thromboprophylaxis, initial venous thromboembolic events, lifelong warfarin with a target INR of 2 to 3. Recurrent venous thromboembolic events, okay, if initial venous thromboembolic event, we will give lifelong warfarin. For prophylaxis, primary prophylaxis, we will give low dose aspirin. And if the event occurred after initial event, we will give lifelong warfarin with the target INR 2 to 3. And if there is a recurrent venous thromboembolic events, lifelong warfarin, if occurred while taking warfarin, then consider adding low dose aspirin, increasing target INR to 3 to 4. You understand, Dr. Tariq?
Yeah, if recurrent is nifedipine is used mostly.
In
In
Raynaud's, yeah.
Okay.
Hmm.
Okay. Diltiazem also we cannot choose. Okay. 1 minute. Okay. Thank you. Okay. Just yes, Doctor. Quickly we will go through this one.
Yeah. So they said this is Raynaud's phenomena is carried by exaggerated vasoconstriction response of the digital arteries and cutaneous arterioles to the cold or emotional stress. It may also primary any Raynaud's disease or secondary Raynaud's phenomena. Disease is the primary, a phenomena is the secondary. Raynaud's disease typically present in a young woman, 30 years old with bilateral symptoms. Secondary causes Raynaud's phenomena, connective tissue disorder, scleroderma most common, rheumatoid arthritis, systemic lupus erythematosus. Okay. These are connective tissue disorder, SLE, rheumatoid arthritis, scleroderma. This is the causes of Raynaud's phenomena. Okay. Leukemia, uh, type 1 cryoglobulinemia, cold agglutinin, use of vibrating tools, drug, oral contraceptive pills, and ergot, cervical ribs. Factors suggesting underlying connective tissue disease, onset after 40 years, unilateral symptoms, rashes, presence of autoantibodies, features which may suggest rheumatoid arthritis, SLE are example of arthritis are recurrent miscarriages, digital ulcers, calcinosis, very rarely chilblains. Management, all the patient with suspected secondary Raynaud's phenomena should be preferred to the secondary care. First line calcium channel blocker, nifedipine, IV prostanoids, epoprostenol infusion effect may last several weeks and months. Okay.
We have the diltiazem and verapamil, which are non-dihydropyridine calcium channel blockers.
Mm.
And that they are saying, this Dr. Saad is saying, we are mostly not using this, we are using the nifedipine. First line calcium channel blockers, for example, nifedipine. Okay, 1 minute,
So this is, yeah.
just 1 minute.
So the use is dihydropyridine.
Diltiazem, okay, diltiazem and Raynaud's phenomenon. Diltiazem can be used to treat Raynaud's. It works by causing some of your blood vessels to relax and widen. This lowers your blood pressure. It also reduces the force and the rate of your heartbeat. So I think this can also be used in Raynaud's UK. Why do calcium channel? So I think many of the calcium channel blockers are used, but the most common one is the nifedipine. Because they are saying first line calcium channel blockers, for example, nifedipine. So I don't know, Dr. Saad, you read somewhere that other calcium channel blockers we cannot use, or what is your idea?
Assalamualaikum, Dr. Tariq. I didn't say anything. I think some other doctor
And
has said
it is mistake, Dr. Tariq. There was another doctor, and since then you are saying Dr.
Okay, sorry. Okay, sorry, sir.
It's okay. It's okay.
Okay, some other doctor has told. Okay.
Yeah.
I told that non-nifedipines, non-dihydropyridines has a more effect on the heart specifically.
Nifedipine has more beneficial effect on Raynaud's phenomena, you mean? Okay.
Yeah.
Thank you very much. Okay. So our patient is
cycline, epoprostenol.
Okay. So IV blood prostacyclin infusions effects may last several weeks, 2 months. Okay.
Mm.
Okay. What is
the
this?
most likely cause of diarrhea? This is colchicine, I think. We will see the scenario. 88
Yeah, you
years.
see here they are saying which has proved negative for Clostridium difficile toxin So this is negative, yani, negative for difficile toxin test.
Yeah. Yeah.
Stool culture negative for this one.
Yeah, Clostridium difficile. 88 years old female is admitted to the hospital for after recurrent mechanical falls. Her past medical history include an anterior resection for sigmoid carcinoma, anterior resection of sigmoid carcinoma for sigmoid, uh, type 2 diabetes mellitus and gout. 3 days into her admission, she was treated for hospital acquired pneumonia with 3 days of intravenous tazocine. 1 week into her admission, she developed a swollen, inflamed second metatarsophalangeal joint, and colchicine was started. After becoming medically stable 10 days into the admission and waiting a package of a care at home, nursing staff report diarrhea with type 7 stool up to 7 times a day. She has no laxative prescribed. One set of the stool culture was sent within 15 minutes of the last episode, which has provided negative Clostridium difficile toxin and microscopy and sensitivity and norovirus. What is the most
This is
likely?
the recurrence of the chronic carcinoma.
Recurrence of colonic carcinoma.
Yes, yes.
Really? How many days,
Because
Dr. Tariq? 7. She discharged. See, when
no,
she
no, previous history of anterior resection for the sigmoid carcinoma.
previous history, okay.
Previous history.
This carcinoma will do seven stools, that much.
Yes, yes, yes. Because other things are negative. You have given here. You have given the tazocine.
And colchicine,
I
Dr.
will also
Tariq.
go through the colchicine.
Can it be colchicine?
This I was thinking, yeah.
As 1 week into her admission, she developed and colchicine was started.
Yeah.
And same
Yes,
duration
I
for
think
the
colchicine here. Colchicine maybe.
Yes.
Yeah.
Yeah, here colchicine. Okay.
Mm.
Yes, because colchicine added, and then he started this.
Colchicine is a classic cause of diarrhea, particularly in the elderly and higher doses, leading to the old age of you run before you walk. Antibiotics can induce diarrhea without infection, particularly those acting on anaerobes. It is unusual in this time frame, having diarrhea 4 days after the antibiotic finish. However, the most serious cause in this scenario is whether tazocine has resulted in pseudomembranous colitis, resulting in Clostridium difficile infection. In this case, negative samples for antigen and toxins are likely to be true negative result. The main concern regards samples that were not transported to the lab promptly within 2 hours, resulting in the breakdown of Clostridium difficile toxins. Hence, a false negative result. There is a little to suggest cancer recurrence or an outbreak of the norovirus. Okay. So it is more likely this colchicine.
Yeah, there is little to just cancer recurrence because if it is without any precipitating cause, we can think of the recurrence of the cancer. But here the drug history is very suggestive of colchicine induced problem. Okay.
This is, what is this? British Society.
So, okay.
Yes, Dr.
Okay, Dr. Zala Khalas. We will go now to the
Other.
next question.
Okay.
So what is
This,
this on the just if you see the X-ray?
yeah. This is the knee. It is knee.
Calcinosis, chondrocalcinosis.
Yes. Knee space
is
is the
chondrocalcinosis?
very finished knee space on the which side? On the left side, on right side also, and there is osteophytes also.
So there is chondrocalcinosis here. You can see inside.
Yeah.
So this is pseudogout. because chondrocalcinosis you see in the pseudogout. Okay. If you see this area, you can see this, Dr. Zala. My cursor you can see.
Yes, I'm seeing, doctor. Yes,
Yeah, this
yes.
is the cursor, and this area is the calcinosis. You know.
Mm,
This is known as the, because it is in the cartilage. This is chondrocalcinosis, and you
mm,
can see this very rough area. You know, haphazard, irregular. Whitening of the tissue here. This is chondrocalcinosis, and this
mm.
is very typical of the pseudogout. I think so. Yeah.
Okay. Chondrocalcinosis helps to distinguish pseudogout from gout.
In gout, you will never see chondrocalcinosis. Okay.
Radiograph demonstrates chondrocalcinosis, visible calcification of cartilage, a sign pathognomonic of pseudogout. So
Mashallah, very good.
calcification in the Dr. Tariq, we can see again one time this.
Yes.
So this
So I
is
will
the
show you this one. You can see.
the white areas. It is the calcification.
You see, this is the this is the bone. This is the
Yeah.
bone also. But inside, there is cartilage. This area is full of cartilage.
And
And this area, if you see this one, this all, this is whitish, and irregularities. And some areas more dense than the other area, white, more white than the other area. This is chondrocalcinosis.
yeah.
And this is very typical of the pseudogout.
Yeah. Okay.
Just I will copy paste this, though it is 1-2 line explanation, but very effective for the exam. Pseudogout.
Pseudogout is a form of microcrystal synovitis caused by the deposition of the calcium pyrophosphate dehydrate crystal in the synovium. For this reason, it is now more correctly termed acute calcium pyrophosphate crystal deposition disease. Okay. Pseudogout, now they are saying no more correctly termed acute calcium pyrophosphate crystal deposition disease. Pseudogout is strongly associated with increasing age. Patients who develop pseudogout at a younger age, less than 60, usually have some underlying risk factors such as hemochromatosis, hyperparathyroidism, low magnesium, low phosphate, acromegaly Wilson's disease. Okay. It is usually a bigger age disease. If they develop below 60, there must be some risk factors. Wilson's, hemochromatosis, hyperparathyroidism, low phosphate, low magnesium, and acromegaly. Features: knee, wrist, shoulder, most commonly affected, big joints, knee, wrist, and shoulder. Okay. Joint aspiration, weakly positively bipharyngent rhomboid shaped crystals. X-ray chondrocalcinosis in the knee. This can be seen as a linear calcification of the meniscus and articular cartilage. Management: aspiration of the joint fluid to exclude septic arthritis. NSAID or intra-articular, intramuscular or oral steroids as for the gout. Okay, we can give oral, intramuscular or intra-articular, intramuscular oral steroid. Okay, an intra-articular can be given. NSAID or intra-articular, intramuscular or oral steroid. And joint aspiration to exclude the septic.
So you can see the linear calcification of the meniscus and cartilage.
Yeah.
And aspiration of joint fluid to exclude septic arthritis, NSAIDs, intra-articular and intramuscular or oral steroids are for the gout. What is this, Dr. Zalim?
They said the management, they
As
said
for it means it's just like gout here.
Yeah, you can give NSAID, you can give steroids. In steroids, oral you can give, intra-articular, intramuscular you can give, and aspirate the joint to exclude septic arthritis.
Yes. So without seeing the scenario, what do you think this one?
Yeah, we will see.
What
the
is in your mind about this picture here? You see it is more whitening or less normal whitening in
No,
the
it's
X-ray?
more.
So more, I think, in Paget's disease.
You
We will see.
means thickening of the cortical
Yeah, yeah.
area.
Yeah, thickening of this is no more calcification of the this
You're right.
periosteum or like that.
Yeah, you are right.
Well, let us see what is this.
Yeah. So they
Okay.
say 70 years old woman present with the 2 years history of worsening hip pain on right side. This is worse on movement, but also occur at rest, including she does not have any other joint affected.
That's
Her
not
body
good.
is 32. So she is obese. On movement, she does not have any other joint affected. And the pain is worse on movement. The past medical history include hypertension, mild asthma, temporal arteritis. Temporal arteritis is there, mild asthma and hypertension. Her pelvic X-ray is as below.
Okay, Dr. Ghazala, it means our diagnosis was wrong. It is temporal arteritis.
Yeah, maybe because they
And
said,
patient will be on high dose steroids.
yes, this is high dose.
Avascular necrosis of the hip.
Yeah, maybe.
So
So
age, bisphosphonates use, inflammatory arthritis, raised BMI, and steroid use. I think steroid use has given this condition.
Yeah.
So see the X-ray again. So see the difference between the two sides.
Yeah.
Length of this, you can see the length of this, Dr. Zala, and length here. Here it is very, very normal, yani, very much normal.
Yeah.
And here there is, this I think this distance is different, yani, not the same, yani. But we will see more pictures, when I will go through the radiology class by Dr. Ahad. He has given a very clear understanding of this one. And you can search by yourself also. But we will discuss this X-ray later on once I will finish the radiology by Dr. Ahad. Because he has explained so many things. Yes.
Hyperdense area of the upper part of the head of the femur is hyperdense, and initially there's thickening. This is that phase of AVN.
You mean all this area, yani? All this area, or
Yes, Dr. That
what do you think? Which area you are saying?
the one you have marked.
Okay, but here also it is like that. It is a little hyperdense, isn't it?
Yeah.
But there can be some changes on the other side also, Doctor. Dr. Saad, yes, obviously, because it is this is steroids are affecting the both sides, but it will be more. It is more prominent on the right. Yes. Okay. So this is related to the steroid use, Dr. Rizal.
Yeah.
Temporal arteritis. Yeah. So avascular necrosis of the femoral head.
This X-ray shows avascular necrosis of the femoral head on the right side. This is shown by the increased bone density, deformity, and flattening of the femoral head. The joint is
okay. We can see some sort of flattening. Yani this is, I think, if you see compare with the other side, I think this is a little flat. Yeah.
Yeah, the right one. Yeah.
Okay.
Yeah. 1 minute. Shown the
joint space. They are saying it is normal. Joint space is normal. Yeah.
Space is relatively preserved, differentiating this from the osteoarthritis of the hip joint. Avascular necrosis is a type of osteonecrosis, which is due to damage to the arterial blood supply to the head and of the femur. The most common cause is steroid use, particularly long-term steroid use. The patient is this patient's the most common cause of steroid use, particularly long-term steroid use. The patient in this scenario has temporal arteritis, which is often managed with the prolonged high-dose steroids. And then age is incorrect. Increasing age is not a risk factor for avascular necrosis of the hip. Outside of the presence of this risk factor, around half of the cases are present in a patients less than 50 years of the old. Bisphosphonate use is incorrect. Bisphosphonate use is associated with osteonecrosis of the jaw, but not the femoral head. Okay.
Yes.
You remember osteonecrosis of the jaw and vertebral bodies? What something?
No, not vertebral bodies, shaft of the femur.
Shaft of the femur. Okay. So two things: shaft of the femur and bisphosphonate. Actually, we are giving to vertebral bodies fracture profile.
Yeah, we are giving in vertebral profile.
Inflammatory.
If the EGFR is if the EGFR is more than 30, we can give.
Hmm.
If
Inflammatory.
less than 30, we will go with the denosumab.
Yeah. Inflammatory arthritis is incorrect. These conditions are not generally associated with ABN unless there is a concurrent steroid use. There may be some association between systemic erythematosus and ABN, independent of steroid use, but this is a much less common as a risk factor than steroid use in general. Raised body mass index is incorrect. This is most significant risk factor for osteoarthritis of the hip, but it's not a risk factor for ABN. Okay. So
Okay.
obesity is the risk factor for osteoarthritis, not for the ABN.
Yes. So inflammatory arthritis itself is will not lead to AVN
Hmm.
unless there is a concomitant steroid use.
Hmm.
Yes. Okay.
So
Okay. Let us see what they have given. Yani, avascular necrosis of the hip, long-term steroid use. You can read this one.
causes of avascular necrosis, long-term steroid use, chemotherapy,
So
alcohol.
this Dr. Swarpa is saying that for the bisphosphonates, they can lead to atypical femoral fractures, not the femoral shaft fracture, atypical. Atypical, not the typical fractures, atypical femoral fractures and osteonecrosis of the jaw. Okay. This is the side effect of bisphosphonates.
Okay. So fissure initially asymptomatic and pain in the factor joint. Investigation, plain X-ray finding may be normal initially. Osteopenia and microfracture may be seen early on. A collapse of the articular surfaces may result in a crescent sign. Okay, there will be a crescent sign. Due to collapse of the articular surface may result in a crescent sign. MRI is the investigation of choice. It is more sensitive than radionuclide bone scan.
Okay, management is joint replacement may be necessary.
Hmm.
Okay, this is also osteonecrosis, avascular necrosis, the right hip. Joint space is normal. And this was over avascular necrosis of the right node, the flattening and subchondral fracture of the right lateral femoral head. So there is fracture of the right lateral femoral head. So there is some, you can see the fracture on this side, on the right.
Yeah, there is, Dr. Tariq. See the upper area? Yes, yeah.
This is the area. And in addition, the right femoral head is smaller than the left. So it is smaller than the left,
Yeah, like collapse, something not globular like the left one.
Yeah. So we'll stop here. Okay. Osteopenia and microfractures may be seen early on. Collapse of the articular surface may result in the crescent sign. I shared in the group last, maybe 1 month ago or 2-3 weeks ago.
X-ray of her left forearm confirm a fracture of the distal radius. A 52-year-old woman.
Okay.
52-year-old woman attends emergency department following a fall down the bottom 2 steps of her staircase and sustaining an injury to her left arm. She denies any pre-syncopal symptoms but describes a feeling generally more lethargic over the last few weeks with generalized body aches and cramps. Her past medical history include chronic kidney disease, stage 1, and she has taken no regular medication. X-ray left for arm confirm fracture of the distal radius. HB is okay, platelet, WBC, sodium is a little bit low. Potassium is okay. Urea, creatinine is little high. Calcium low. So sodium and calcium both low. Phosphate is also low. Minerals low all. Sodium, calcium, phosphate. Alkaline phosphatase also high. Shreya. Parathyroid hormone also it's normal.
Normal.
Yeah. ESR 22 more. So ESR more, sodium, calcium.
So Dr. Zala, this is okay. This one is low calcium, low phosphate, high ALP. It is like osteomalacia.
Mm, mm.
I think we will go in favor of osteomalacia.
Yes, yeah.
Tertiary hyperparathyroidism, Paget's disease, osteoporosis, osteopetrosis, osteomalacia. Okay, let's go with this one. Let's see.
Osteomalacia, low calcium, low phosphate, raised alkaline phosphate. Low phosphate, low calcium, and raised alkaline phosphatase. This patient has a diagnosis of osteomalacia. Osteomalacia is the demineralization of the bone, most commonly secondary to vitamin D deficiency. Patient with osteomalacia typically present with bone, knee pain, muscle tenderness, proximal myopathy, and increased tendency for fracture. Proximal myopathy, muscle tenderness, and bony pain. And increased tendency to fracture, this is osteomalacia. Bone blood test reveals low calcium, low phosphate, raised alkaline phosphatase. As seen here, this patient describes a history of lethargy. This patient describes a history of lethargy and body aches and cramps that is likely a result of hypocalcemia. Osteopetrosis, also known as marble bone disease, is a disorder of the osteoclast function that impairs bone resorption. This results in dense bones that are likely to fracture. Bone pains are common, like those described by this patient. However, on laboratory testing, calcium phosphate and aluminum alkaline phosphatase likely are normal. So osteopetrosis, all these calcium phosphate and ALP will be normal. And in osteopetrosis, osteoclast activity is the problem one.
Yes.
Yeah. So the bone will be continuously formed, mineralized. That's why it become rigid and prone to fracture, I think.
Yes. Okay, we'll go to the next now.
Mm.
Very nice. Okay, I will read now, Dr. Dana. Thank you very much for long discussion. And we will go to the next question now. Okay. So which antibiotic prescribed for his for this lady could explain this picture? Also, we can in osteomalacia we can see the pseudo fractures, no?
Yeah. Yes.
So which antibiotic prescribed for this lady could explain this picture? Trimethoprim, I think here most likely, and see the monocytes, lymphocytes, neutrophils. So there is bone marrow suppression, pancytopenia. You can say bone marrow aplasia, and patient may be taking the methotrexate, and along with that trimethoprim, then patient has gone into to develop the aplastic anemia, or you can say pancytopenia. 65-year lady is admitted to the hospital after the GP noted an abnormality in routine blood. She is known to suffer from rheumatoid arthritis. Current medications include methotrexate. Okay, so we will go for the answer now.
Yeah.
So the concurrent use of methotrexate and trimethoprim containing antibiotics may cause bone marrow suppression and severe or fatal pancytopenia. The mechanism, is the conversion. They will stop the conversion of the folic acid into the dihydrofolate into tetrahydrofolate.
Yeah.
Because they will they will stop in. They are the inhibitors of the enzyme dihydrofolate reductase. So they are dihydrofolate reductase inhibitors, both of them. So double or triple, you can say, inhibition. And this tetrahydrofolate is a very important component for the synthesis of DNA and replication mitosis. So all your cells will not, you cannot get the replication, and you will end up with a bone marrow suppression, leading to this picture of this blood picture, which is there, pancytopenia. Methotrexate, the folic acid antagonist affecting the cell cycle. Trimethoprim is also a folic acid antagonist. Okay. When we are saying folic acid antagonist means tetrahydrofolate, you will not get. Okay.
Yes.
When combined together, the risk of myelosuppression is increased, given also the fact that trimethoprim reduces the renal excretion rate of methotrexate. So there is double action, Dr. Zala, here.
Yeah.
One is the inhibition caused by trimethoprim along with methotrexate, and the second is
Doesn't know we can hear him.
I will write it message.
Yeah. Yes, write a message.
okay. Sorry, guys. Actually, my mic was off. You can't listen. Okay. Sorry, Dr. Mustafa. Sorry, guys. So this one is, I was talking about this methotrexate, and we know the mechanism of action and indication of inflammatory arthritis, especially rheumatoid arthritis, psoriasis, some chemotherapy it will act just like some sort of chemotherapy in acute lymphoblastic leukemia. And adverse effects, there are two itis-like things like inflammation, two types of inflammation, one of the mucous membrane, other of the lungs, parenchyma. And there are two types of fibrosis. One is the pulmonary fibrosis, the liver. So, and also in the pneumonitis, the most common pulmonary manifestation, a similar disease pattern to hypersensitivity pneumonitis, secondary to inhaled organic antigens, typically develops within a year of starting treatment, either acutely or subacutely, presents with non-productive dry cough, dyspnea, malaise, and fever. Pregnancy, we mentioned.
You similar disease pattern to hypersensitivity pneumonitis. So it will
Yes,
be
exactly.
upper lobe or lower lobe.
This hypersensitivity will be upper lobe and methotrexate pneumonitis lower lobe, but the disease pattern will be the same. Yani.
Yes,
Presentation will be the same, otherwise like cough, dry fever, dyspnea, malaise, fever like this. Yeah, that will be the same. Yeah. And women, and especially, hypersensitivity pneumonitis has different causes. And one of the cause when it will be due to inhaled organic antigens, and then lead to hypersensitivity pneumonitis. This will be exactly similar to that of the methotrexate pneumonitis. Okay. So if some other cause of hypersensitivity pneumonitis, maybe that will be having some differences from the methotrexate pneumonitis. But if it is due to inhaled inhaled organic antigens, this hypersensitivity pneumonitis, this will be having the same pattern as methotrexate pneumonitis. And pregnancy, women should avoid pregnancy for at least 6 months after treatment has stopped. And also for the, they should avoid the BNF also advises that men need to use effective contraception for at least 6 months after treatment. Okay. So after, when you stop the treatment, men also need 6 months for the contraception, and the women also should avoid the pregnancy for at least 6 months. And prescribing methotrexate, we know we are using the single dose, and is a drug with a high potential for patient harm. Is therefore important that you are familiar with guidelines relating to its use. Methotrexate is taken weekly rather than daily. So if you give yourself in the primary care, somebody methotrexate or secondary care, we need to insist and write on the label that it is a weekly drug, not a daily drug. And full blood count, urea electrolytes need to be regularly monitored. So you will check it weekly. And once the dose will be stabilized, then you can that's every 2-3 months. Okay. So the Committee on Safety of Medicine recommend FBC and renal and LFTs before starting treatment, and repeat weekly until therapy is stabilized. And thereafter, patient should be monitored every 2-3 months. Okay. So folic acid 5 mg once weekly should be co-prescribed, taken more than 24 hours after methotrexate dose. The starting dose of methotrexate is 7.5 mg weekly. This is according to BNF, and we should give the one strength only. Usually we are giving a strength of 2.5 mg per tablet. Okay. So only one strength of methotrexate tablet should be prescribed, usually 2.5, because the starting dose is usually 7.5. Interactions: avoid prescribing trimethoprim or co-trimoxazole concurrently, increase the risk of marrow aplasia, and high dose aspirin increase the risk of methotrexate toxicity, secondary to reduced excretion. So it means that there are two things which are decreasing the excretion: trimethoprim as well as high dose aspirin. Low dose aspirin will have no problem. Methotrexate toxicity, treatment of choice is folinic acid, and please remember, folinic acid is it is not dependent on the conversion from it will not depend on the enzyme dihydrofolate reductase, okay, inhibitor. So sorry, that enzyme dihydrofolate reductase enzyme, this folinic acid is not. So this is a direct drug. This is basically a folate, and in toxicity, What is the side effect of toxicity mainly is bone marrow aplasia. And how you can overcome? You just give folinic acid and your white cell count, platelets and red cells go up quickly. So what would be the most appropriate first-line investigations for the diagnosis? Cervical X-ray, HLA-B27, MRI spine, pelvic X-ray, and the rheumatoid factor. 21-year-old man presents with GP with severe amounts of low back pain and wakes up with stiffness in the back that persists for more than an hour. There has been no obvious injury and his keen sportsman finds that symptom improve with exercise. So this is ankylosing spondylitis. Sitting at his office desk for prolonged periods appears to exacerbate symptoms. There is no signal PMH except for an episode of uveitis approximately 1 year ago. So you know the association of uveitis, anterior uveitis and Achilles tendonitis and AV nodal block and amyloidosis. And there are so many things, you know. There is Cohen syndrome and there is peripheral arthritis and there are so many things that you can remember. This is pelvic X-ray is the first line will be pelvic
Apical
X-ray.
fibrosis.
There
Apical
will
fibrosis
be
also. Huh?
Pelvic X-ray or MRI
apical
spine,
fibrosis
initially
also.
the
Apical
change will
fibrosis.
not be evident on X-ray?
What?
You know, first
Pelvic
time,
X-ray first. First line is
line-
pelvic X-ray.
first line is X-ray for sacroiliitis of the hip joint, you know. Sacroiliitis of the sacroiliac joint, not the hip joint, sacroiliac joint.
Sacroiliac joint we have to see, yeah.
Yeah, and if it will be negative, then you can go with the MRI spine, okay, MRI. And MRI of the spine, you can see the edema. Edema will be there in that areas of affected areas will be showing some sort of edema.
And in pelvic X-ray, we will see sclerosis and irregular narrow joint space and irregularity of the joint line.
Yeah.